This is the second section in cochlear implant candidacy. Here we cover adult cochlear implant candidacy, and this is related back to Chapter 2 of the textbook Cochlear Implantation by Gifford.
And then for adult cochlear implant candidate selection, we're talking about 18 years and over, and that's not in CAT years. In the United States, the FDA first approved cochlear implantation for adults in 1985. Since that time, cochlear implant candidacy has evolved quite rapidly. Current considerations for candidacy are going to include age of the person, etiology of hearing loss, insurance coverage, and cochlear implant manufacturer. All of those four factors will play a role in determining candidacy for adults. While there is no specific upper limit for age, usually considerations are related to overall health status, ability to undergo surgery, cognitive status, motivation, etc. Etiology of hearing loss would be, is it related to, is there single-sided deafness related to acoustic neuroma removal? Is it related to meningitis? Is it conductive, sensory neural? Things like that. Insurance coverage is pretty straightforward. If it's a older adult, of course, we're talking about Medicare. If it's someone under the age of 65 or a child, then we're talking about various third-party payers, Blue Cross Blue Shield, United Healthcare, Coventry, etc. And each individual cochlear implant manufacturer will have their own set of candidacy criteria because each develops their own device and submits them independently to the FDA for review. In terms of what we should do for audiologic evaluation, it's pretty standard to what we see in our basic test batteries. Pure tone audiometry, the big exception would be we want to include 125 hertz as opposed to usually going down to 250 hertz. When you're dealing with populations that are potentially CI candidates, they're typically going to have much worse hearing. You may see corner audiograms. When we talk about some of the new hybrid cochlear implants, we're preserving acoustic hearing in the low frequencies and only supplying electrical hearing in the high frequencies. We also want to take a look at 125 hertz so we can see if hearing thresholds are worsening at all post implantation of these hybrid implants. And then, bone conduction up to 4,000 hertz, same as we'd normally do with a typical test battery. Going to continue to do speech recognition threshold, word recognition testing. That should be no surprise. OAEs are probably not of great value because most persons who are going to be cochlear implant candidates would not have OAEs to begin with. The one potential exception would be those with auditory neuropathy, but if they've been using hearing aids for any length of time, there's very likely that's going to help the noise exposure from the hearing aids is going to help abolish those OAEs. So OAEs are probably not critical, but it certainly wouldn't hurt to do. When we talk about different audiometric threshold criteria, we can see how they differ across manufacturer here. The three major cochlear implant manufacturers: Advanced Bionics, Cochlear, and Med-El, as well as the Center for Medicare and Medicaid Services, CMS. We can see that it's for both Med-El and Advanced Bionics, number 2 and 3 in terms of the size of cochlear implant manufacturers. They both have severe to profound losses. The Advanced Bionics does not specify which thresholds are used in that calculation, whereas Med-El specifically designates the 3-frequency pure tone average. But we can see it's a little bit looser criteria for both Cochlear and for CMS coverage, indicating can be a moderate to profound loss. So if you want to visualize what the moderate to profound loss looks like on an audiogram, for example with Cochlear America's criteria, you can see here that orange area. We can have thresholds in the low frequencies there, 125 to 500 hertz, as good as 40 dBHL, and then at 1,000 hertz and higher, they must be within the profound region. So you can see low frequency. That's partly why it's important to assess 125 hertz for audiometric thresholds, especially when dealing with cochlear or with hybrid cochlear implants. But we don't always want to solely deal with detection thresholds. We will also need to understand how the individual candidate is able to utilize the information made audible. If we kind of rewind and think back to either some psychoacoustics course or introductory psychology courses, we remember sensation versus perception. When we talk about sensation, we're talking about the ability of our auditory's sensory receptors to convert that into neural impulses to send up to the brain. And the brain is going to interpret that as auditory image, a visual image, some olfaction, gustation, etc. And so if we think about the ability of our ability to detect the presence of a sound, that would be sensation. So detection would be synonymous with sensation in this case. But the higher order abilities of interpreting that into something meaningful, to organize that lower level auditory information and translate it into something that has meaning to us, would be perception, or in our case, for what we test, something like sentence recognition or word recognition. The question with these tests of perception or recognition abilities is that there's really no standard for us. There was no standard in terms of what types of materials to use for assessing perceptual abilities, either pre or post-op for cochlear implant candidates or recipients. So back in 1996, AAO-HNS, aka American Academy of Otolaryngology, Head and Neck Surgery, got together with American Academy of Audiology in conjunction with some audiologists and scientists from the three cochlear implant manufacturers, and they created something called the minimum speech test battery, and this is for adults. This was used to guide clinicians and researchers in terms of what types of materials they should use for assessment, for outcomes. Well, they originally settled on the HINT in quiet. It's kind of a misnomer because HINT is an acronym for hearing and noise test. So hearing and noise test in quiet seems a bit silly to say, but it's really what it is. HINT without the background noise was used in the first version of this MSTB, the minimum speech test battery. Later on, they found that it was a bit too easy, and they ended up, the current version, the 2011 version, they're recommending use of these AZ bio sentences, which are more difficult sentences that have less context than the HINT sentences, both AZ bio sentences in quiet and in background noise. We don't really see the AZ bio sentences in other areas of clinical audiology. It's mainly cochlear implant audiology. Also, the BKB SIN is another good option, and the CNC words. CNC words are basically like monosyllabic words. So we've talked about the types of materials recommended by the MSTB for assessment of cochlear implant candidacy, but we also need to talk about recorded versus live voice presentation of the materials, recorded versus live voice. I'm sure you all recall the benefits of using recorded materials, the standardization that you get across clinics, within the same clinic over time, especially if you have different audiologists working with patients, the ability to compare things back to a normative data set. However, we do know from professional practice surveys that nearly 2/3 of audiologists use live voice. Now, these surveys are a bit dated, 98, 99. Actually, the surveys were conducted, probably a couple years prior to that, but we don't have newer data at this time, so we can still operate under the assumption that the majority of clinicians are probably using live voice. We don't know necessarily how that may differ in terms of an implant center versus your average audiologist in a clinical setting, but again, we need to operate under the assumption that live voice is still widely used. While this probably isn't as much of a problem for things like SRT assessment, it is a problem for word recognition testing or sentence recognition testing. Ross Roser and Jackie Clark highlighted this in a 2008 paper in Audiology Today. They compared word recognition testing from 16 patients for the right and left ear. You can see that on your screen in front of you. Figure 1A is the right ear. Figure 1B is the left ear. I may have shown this to you in a previous class. What we can see here is that the live voice testing, indicated by the thinner red and blue lines, or basically the top curves in each of these figures, the live voice testing is really between 80 to 100% for most patients. And below that, we have the recorded testing. So the red squares on the left side for the right ear, and the blue squares on the right side for the left ear. And then what we have is the Thornton and Raffin confidence intervals, the bars attached to each of those scores. we can see that for each of these 16 patients, live voice is pretty much better in terms of scores than recorded. Maybe there's a couple patients here that have equivalent scores, but in no case here is live voice worse than recorded. But I think the most powerful finding is that you can see that there is a much wider spread for the recorded versus the live voice. You can see differences between these 16 patients. We can see that 2 patients on the left are scoring 0% on recorded materials for the right ear, and actually for the left ear as well. And then we can see the patients on the right side for recorded materials are scoring up to, say, 85% on that right ear. But we can see the spread, so that's a spread of about 85%. But the spread over for the live voice material is 20%. So really what we're able to do with these recorded materials is we can better characterize perceptual abilities. What we can also say is that we know that the manufacturers and CMS are behind this. Cochlear Americas and Med-El, as well as the Center for Medicare and Medicaid Services, are all behind the use of using recorded materials. I do not believe Advanced Bionics has put out a recommendation for recorded materials, but they certainly may in the near future. So we've talked about the types of speech materials. We talked about the method of presenting it, whether it's via recording or whether it's live voice. We also should take a little bit of time to talk about the presentation level. So historically, these materials, like the hint and quiet, for example, were presented around 70 dB SPL in the sound field. 70 dB SPL is consistent with a raised vocal effort as opposed to a conversational vocal effort. And that was used for a while because the idea was that persons with severe to profound loss, who are most often candidates for cochlear implants, are not going to do well with lower levels of speech in the sound field, so 60 dB SPL, even when aided. And that's true, but the problem, there's a couple problems with that. One would be that it doesn't really do the candidate any favors, because people are typically talking at a conversational level on average around 60 to 63 dB SPL, and so testing them while people are using raised vocal efforts in order to produce louder speech around 70 dB SPL isn't exactly fair to that candidate, the potential candidate, since we're using sentence recognition scores in order to determine candidacy. So in recent years, there's been a trend to shift things down to 60 dB SPL presentation levels, because that's more representative of conversational level speech, and probably more importantly, is it's going to open up the door to more candidates. It'll yield lower pre-implant scores, so more people will be candidates for cochlear implants, and it also shows greater benefit overall. If we compare pre-op scores and post-op scores, we're going to see that people have a greater percentage change in terms of benefit. Okay, I mentioned earlier that the MSTB specified which types of speech materials to use. So in the current iteration, say the monosyllabic CNCs and the hint and quiet or hint and noise, maybe the BKB syn and AZ-bio sentences. But in the MSTB, they didn't specify the criterion performance, so we're left to look at what the manufacturers had. In truth, they couldn't really specify the performance if they had already been FDA approved. They can't just change those. They'd have to go back and reevaluate things and submit applications, which are costly. Okay, but the MSTB does recommend, for example, with the CNC word list, to use a 50-item list as opposed to the 25-item list that we so commonly use in clinical settings for other types of monosyllabic words like W22 and NU6. They also propose using two 10-sentence hint lists, and that seems pretty fair. The more items we have in a given test, regardless which type of speech test it is, the more powerful it is at being able to differentiate performance across time or across subjects or across ears. And the MSTB also recommended using the hint, using a fixed SNR. So basically somewhere between plus 10 dB SNR down to 0 dB SNR. And the more difficult conditions are there to avoid. avoid reaching the ceiling or effects of getting 100%, for example. But these recommendations by the MSTB are not the same as the candidacy criterion or criteria put forth by cochlear implant manufacturers and approved by the FDA. On all of them, they're looking at open set sentence recognition. So sentence recognition is pretty straightforward. Open set meaning they don't get a variety of choices to look at. So in contrast to something like the SSI, the synthetic sentence identification that you learned about with Dr. Downs, on that particular test, that speech and noise test, when there's ipsilateral competing message, if you recall, the client has a list, I believe, of around 10 sentences they can choose from. That would be a closed set. So this would be open set. Open set like we do with all of our, the majority of our speech testing we do for adults. And as mentioned before, both Med-El and Advanced Bionics recommend the hint. They specify the hint, but Cochlear Americas does not specify which. So you could pick the AZ Bio, you could pick BKB Sin in quiet, so without noise. You could pick, heck, I guess you could pick really any open set sentence test for Cochlear Americas. And then in terms of that criterion which the manufacturer puts forth, it varies depending on the manufacturer between 40 to 60% in the best aided condition, with Med-El doing 40% correct, no more than 40% correct in the best aided condition. Advanced Bionics, no more than 50% in best aided condition, and then Cochlear, no more than 60% in the best aided condition. Cochlear also says that no more than 50% in the ear to be implanted, so that would be assuming that you're doing some kind of ear-specific testing. So I suppose there you could put masking noise in the non-candidate ear, the ear you're not going to implant. And as mentioned earlier, more recent recommendations by professionals in the field or experts in the field have been pushing away from the hint and more towards a combination of the AZ Bio sentences, the BKB Sin, and then the CNC words. And so combination of recognition and quiet, recognition and noise. And that's mainly because the hint is too easy for a lot of these cochlear implant recipients post-implantation, and every once in a while, even before implementation. Another important thing to remember that may get overlooked sometimes, especially if a potential cochlear implant candidate is coming in from a different facility. So say, for example, a potential candidate was referred by a local hearing aid dispenser or local audiologist, even not local, farther away, a couple hours away. They may be coming in with hearing aids that you did not dispense from that clinic. But you may be charged with doing the candidacy evaluation in the sound field, measuring percent correct with the hint and quiet, or whatever materials you're using, AZ Bio for cochlear maybe. But it really is your job as the cochlear implant audiologist, or in the evaluation process, to make sure that the hearing aids are operating as they should be, to verify that the hearing aids are set appropriately. Otherwise, they may score worse, for example, than they should, and you may be qualifying somebody as a cochlear implant candidate when they shouldn't be, because the residual hearing is better than what you're getting. So, of course, we want to verify it like we'd verify any set of hearing aids. We want to use real ear measurements, whether that's insertion gain or whether it's measuring output and SPL at the eardrum with real ear aided responses or real ear aided gain. It doesn't really matter, but we wanted to verify using probe mic measurements, and we can do that according to the criteria set forth in AAA's 2006 guidelines for audiologic management of adults. And you also probably want to use, in particular, verification stimuli at around 60 dB SPL. I know when we're verifying hearing aids for fittings of clients who may use different levels, 65 dB SPL, maybe we'd use various levels, 55, 65, 75 dB SPL. But we want to verify for 60 dB SPL in particular, because that's the presentation level we're probably using for speech to begin with. But we do want to be realistic about this. We want to make sure that we're trying to match it to NAL or DSL targets, and hopefully, if it's a client that hasn't been fit at your clinic, that maybe you have the software and ability to adjust the aids. we want to approximate targets as best we can. We know that won't always happen, especially with some of these potential cochlear implant candidates. You certainly may not always be able to match targets in the mid to higher frequencies, depending on the loss due to feedback or limitations of the hearing aid. So we want to be realistic about what our expectations are, but we don't want to skip the step of verification. So we can see in this whole establishing cochlear implant candidacy process, the audiologist does play a major role here. Usually the ENT physicians aren't going to be familiar or interested in all the nuances related to what we're talking about, the materials used, the levels used, these things that aren't specified in the FDA the physician inserts for the devices. These may be things that the audiologist needs to consider. So this could have a bigger impact on who you're implanting at the facility you're working at. You recall from the previous talk on the percentage correct, or the criteria required for cochlear implant candidacy in terms of speech perception or word recognition abilities, that many times was referenced back to the best aided condition. But Fabry and colleagues in 2009 published a paper arguing that we probably shouldn't be using the best aided condition as the reference. We probably should be using the implanted ear, or the implanted ear pre-implant versus post-implant. So using that as the reference, which typically would result in a lower score and maybe qualify more candidates. We can see that Cochlear does use this combination of best aided condition and the ear to be implanted, whereas the other two companies, Med-El and Advanced Bionics, are just referencing best aided condition. We will just have to wait and see how that changes as things move forward. And when we're testing in these best aided conditions, or when we're testing the implanted ear, we're doing so with hearing aids on, so we need to do this in the sound field. So in the sound field measurement of aided speech perception abilities, we're typically positioning the candidate or the client about 1 meter back. 1 meter back is standard. That's where the calibration technicians that come in and calibrate your sound field speakers, that's where they're calibrating at. So this isn't something special for cochlear implants. 1 meter back is standard. But what you do need to realize is that we really shouldn't be doing aided testing for anyone in booths that are smaller than 6 by 6 feet. So basically 2 meters by 2 meters. And the problem with doing testing in those smaller booths is going to be smaller deviations in head position or head movement may have a much bigger impact on SPL at the eardrum. And so there's going to be greater risk for erroneous or unreliable or inconsistent test findings with these teeny tiny booths. So implant centers definitely need to have booths at a minimum of 6 feet by 6 feet. But usually in medical settings, that shouldn't be a huge problem. So here's an overall look at the MSTB recommended adult candidacy workup check sheet. We can see we've got the comprehensive evaluation, audiologic evaluation. We've got thresholds, both air and bone. Remember, air going down to 125 hertz. We've got speech audiometry, including SRT, word rec, tympanometry, reflexes, decay if you have reflexes that are present. Notice we don't have OAEs on there. That's okay. Hearing aid verification, making sure that we have either insertion gain or output at the eardrum is appropriate, verifying with 60 dB SPL input, preferably with speech. If we don't have something like that, then we can use some type of noise that is going to be speech shaped, like Eichner noise or something like that. Aided speech recognition testing, again, the hint may be one, but that you may be using to qualify for Med-El or for Advanced Bionics. But some of the newer ones that are recommended are the CNC words, the AZ Bio, BKB SIN. And then also questionnaires are something that we haven't really addressed, but these are going to be important. So expectations, making sure clients have realistic expectations of what's going to happen once they're implanted. And then a pre-implant administration of outcomes measures, so basically quality of life before the implant so that you can measure it later on down the road and look at change or benefit in terms of quality of life with the implant. Overall, this cochlear implant workup, this audiological cochlear implant workup, should take right around 2 hours, and this is based on a, I believe, unpublished thesis by an audiology student in recent years. believe Fabry has recommended a revision to the cochlear implant workup battery to cut it down closer to about an hour or less, but I don't think that's been adopted. Okay, speaking of different types of questionnaires, there was the expectation questionnaires and also the outcomes questionnaires that we're interested in. Expectation questionnaires are available from the Cochlear Corporation. I believe they developed one particular expectation questionnaire, and there are probably others out there that I'm not aware of. The other type of questionnaire that we're interested in is outcomes questionnaires. So basically, we want a before and we want an after in most cases. We can use many hearing aid type questionnaires, or questionnaires that were originally developed for hearing aids can easily be used for assessing cochlear implant benefit. If your facility that you're working at, your cochlear implant center, also does a lot of hearing aids, you may just want to use the same types of questionnaires for both populations. For example, the COSI and the AFAB we're most familiar with because they're built into NOAA. They're very easily accessible. You can also use other ones that are less popular but also good questionnaires, like the GHABP, which is kind of a sort of like a combination of a COSI and AFAB combined. That's the Glasgow Hearing Aid Benefit Profile, also available online for free. You may be also interested in some specific cochlear implant questionnaires. There's going to be an example would be the Cochlear Implant Function Index, and I've got a screenshot of that in front of you. It's a very long questionnaire, 60 items. So, it's maybe not exactly something you want to do with the older adult population, but I think a lot of people it would work well for. Not to mention for something like that's such a big deal, like a cochlear implant, as compared to a hearing aid, where hearing aid you've got a 30-day trial period typically. Cochlear implant, there's not really that trial period. Once you go through with it, you can wear it or you're not, but you've gone through a big long process, and so definitely, the length of the questionnaire is not something I'd be hugely concerned with, but this is going to be, much more targeted towards cochlear implant recipients than something like an AFAB would be. Then we've also got quality of life assessments, which are probably going to be used more often in a research setting, but I couldn't say for certain that they're not commonly used clinically. But quality of life assessments would be more generic. For example, the Health Utilities Index Mark III is one. And these could be used, for example, not only with cochlear implants. You could use these with things like knee replacement, or you could use any kind of pacemaker implanting or a stent. Changes in quality of life following any kind of large procedure to see how it's going to benefit you overall. And so that would be for more something that you want to compare quality of life improvements for cochlear implant versus some other unrelated type intervention. Other than the audiologist, another professional that may or may not be involved in the candidacy process for adults would be either a licensed clinical social worker or a psychologist. What they can typically do overlaps quite a bit for a master's level master's level social worker and a psychologist. While in earlier years with cochlear implants it was routine to have a psychological evaluation prior to getting an implant, this isn't quite as common in recent years, but there may be certain subpopulations who are cochlear implant candidates that are adults that may benefit from getting a psychological evaluation prior to proceeding. In particular, those who have sudden onset sensorineural hearing loss of severe to profound degree, so that sudden change in their hearing abilities, there's a sense of loss and coping that is going to be going on there, and a psychologist may be able to help them through the process and help make sure that the cochlear implant is psychologically one of their best bets. And then also those with prelingual hearing loss, many cases congenital, but really prelingual is the key thing. Realizing what to expect and down the road from the cochlear implant, and making sure that in particular if there are any mental health issues secondary to the hearing loss, such as anxiety, depression, etc., that the individual candidate has reasonable expectations about what that cochlear implant might do for them. So as an example, someone who has hearing loss but they happen to have severe depression or some kind of anxiety disorder, that is certainly possible that could be unrelated to the hearing loss entirely, and maybe they're seeking to get a cochlear implant to resolve these mental health issues that are unrelated to the hearing loss. So a psychologist or licensed clinical social worker could help better evaluate the situation to determine if psychologically that they're a good candidate. Of course, the otologist or neuro-otologist performing the implant procedure will definitely also determine the candidacy of the particular person in question. So the audiologist's workup typically comes first, audiometrically, to make sure they're a candidate both in terms of pure tone thresholds and speech recognition abilities. But then the otologist doing the workup is going to make sure that the patient is up to date on their vaccines, in particular for an adult, so pneumococcal vaccines, flu vaccine, etc. They're also going to make sure that there's no medications that could pose a problem for surgery if they're on anticoagulants like Coumadin or heparin or things like that. Also going to make sure that they're healthy enough for general surgery, so that anesthesia, putting them under with anesthesia, wouldn't cause any respiratory concerns and undue risk. Also going to look at their general vital signs. They're going to do a medical evaluation, overall medical evaluation, make sure their health is okay to undergo the surgery. For example, there might be certain populations that would be at a greater risk if they have autoimmune issues like HIV/AIDS or lupus or other potential autoimmune disease. CT is fairly routine. MRI is a little bit less common, especially CT with acquired hearing loss. May not always be performed, but usually they're going to perform a CT to make sure that the cochlea, take a look at the cochlea and auditory nerve, make sure the auditory nerve is not abnormally small or missing or anything like that. The MRI might be more common when there's asymmetries in hearing loss to make sure there's no tumor impinging on the auditory nerve. Then, of course, the surgeon is going to go over informed consent in terms of what the potential patient can expect, potential side effects or complications from the procedure. Okay, let's move on to certain variables that may be predictive for postoperative outcomes, or at least these factors have been looked into to see if they're predictive. I think many audiology clinicians would hypothesize that some older adults may not always be good cochlear implant candidates due to potential health risks associated with the typical aging process. However, this has been looked at in several studies, and they found that those older adults older than 70, and even those who may be into their 90s, really are not at greater anesthetic risk compared to their younger cochlear implant candidates, and they may also receive equivalent benefit overall compared to younger cochlear implant candidates. So a bit of a surprise, but definitely a positive surprise, because that opens up the door for more presbycusic related hearing losses to receive intervention with cochlear implants. A contraindication, though, that is related to the aging process would be dementia or Alzheimer's, or even potentially just mild cognitive impairment, I guess, depending. Those may be contraindications for implantation. So what about audiometric thresholds? How well can those predict outcomes? We know that, in audiology in general, we know that pure tone thresholds don't really accurately predict word recognition or speech perception abilities. To some extent, they do. We talk about the Thornton and Raffin confidence intervals, or critical differences rather, and you can talk about how not the Thornton and Raffin critical differences, but the sprint table, where we've got Thibodeau's sprint table, where we've got the 95% range for word recognition abilities based on pure tone average, but that range is pretty wide. And in general, pure tone thresholds aren't really great predictors of word recognition or speech perception ability. We know people with very, very poor very, very poor audiometric thresholds may tend to have worse speech recognition ability, but they're not great predictors. So it may not be that big of a surprise that the pre-op pure tone thresholds really don't predict post-op speech perception abilities well at all. But a little more surprising might be that there's not even a correlation between spiral ganglion cells and post-op speech perception abilities. Now we know that we can't really measure, we can't count spinal ganglion cells in live humans, but for those who have received implants and passed on and donated their bodies to science, post-mortem temporal bone studies can be conducted, and there they can count spiral ganglion cells and relate it back to cochlear implant performance prior to death. Some other interesting factors to consider would be duration of deafness and pre-op speech perception abilities. So, do pre-op speech perception abilities relate to post-op speech perception abilities? That would be a very reasonable, I think, hypothesis. And then, does duration of deafness relate to post-op speech perception abilities? Well, it turns out, in general, there's only a weak correlation there. There's not a very strong correlation. So what we can say is that for those that pre-op score about 0 and have not been deaf really for more than 20 years, there's really no correlation. Now, for those that have pre-op scores of 0% and who have been deaf greater than 20 years, there's a weak correlation. How well can that predict abilities? Maybe duration of deafness could predict maybe 36% of the could account for 36% of the variance with post-op speech perception abilities. When we talk about pre-op abilities predicting post-op abilities, we can say that those pre-op abilities may predict, say, 13% of the variance in post-op. That's based on the Rubinstein data with the graph from the textbook. So in general, really, what I'm getting at is pre-op speech perception abilities and duration of deafness are very weak predictors, not useful clinical predictors of post-op speech perception performance. So far, we've got pure tone thresholds pre-op, speech perception pre-op, and duration of deafness. None of those are terribly useful in predicting post-op speech perception outcomes. And then we may also want to consider certain medical conditions, certain ear diseases, and how well those, or how they will impact post-op benefit or speech perception abilities. We've got meningitis and we've got otosclerosis. In the case of bacterial meningitis, although they are more common in children, it is more common in children than adults, it is still fairly common in adults. And we know that meningitis can be related to ossification of the cochlea, is what we think about most often. And also issues of spiral ganglion death and also hair cell death, secondary to labyrinthitis. So due to that ossification, oftentimes the otologist or neurotologist may not always be able to fully insert the electrode array, and as a result, we may have less stimulation by the electrode array. Fewer electrodes will be activated, and so really overall less benefit with meningitis, and so the client may need to be counseled that less benefit may occur. In contrast, otosclerosis typically has very positive outcomes, very good outcomes, but over time, due to continued progression of the otosclerotic disease process, some of those electrodes that were previously usable may no longer become usable anymore, and so performance may decrease somewhat over time, but in general, otosclerotic ears have good outcomes. And that concludes adult cochlear implant candidate selection.